Hi guys, welcome to Concise Approaches of Internal Medicine. My name is Giovanna Perez. In today's video, we'll be talking about controversies in the use of anticoagulation in chronic kidney disease. Chronic kidney disease is a major global public health problem, being closely connected to cardiovascular disease. Chronic kidney disease involves an elevated thromboembolic risk and requires anticoagulation, but the high rates of hemorrhage render it quite challenging. Hypertension and diabetes mellitus are the primary causes of chronic kidney disease. Chronic kidney disease is recognized as independent risk factor for the onset of cardiovascular disease. One of the latest United States renal data sites reports that the prevalence of any cardiovascular disease is double in patients with chronic kidney disease, estimated at 69 to 8% in the general population. Also, microalbuminuria is detected and glomerular filtration rate is less than 60 milliliters minutes. There is an increasing rise of cardiovascular events and mortality. The risk of atrial fibrillation and acute coronary syndrome is double in patients with glomerular filtration rate less than 60 milliliters per minute. The association between atrial fibrillation and chronic kidney disease engenders a much higher thromboembolic risk, which in case of ischemic strokes range from 26% to 49%. We must be aware that exists a bidirectional relationship between cardiovascular disease and chronic kidney disease is due to the intervention of major cardiovascular risk factors shared by both disorders. Currently, chronic kidney disease entails factors that are frequently involved in uremia, system inflammation, oxidative stress, activation of the renin-angiotensin-aldosterone system, anemia, microalbuminuria, and hyperhomocysteinemia. Also, abnormalities in bone and mineral metabolism. Vitamin D deficiencies play an important role. All of these impact directly on the cardiovascular system. This results in hypercoagulable state that generates arterial and venous thromboembolic complications, as well as the progression of the kidney disease. The pathophysiology substrates involves in three components of virtuous triad. First, turbulent blood flow, vascular endothelial injury, and hypercoagulability. Now, in the treatment, we have benefits and problems. First, start with oral anticoagulants, vitamin K antagonists. The benefits of warfarin in atrial fibrillation patients with mild and moderate chronic kidney disease to reduce stroke is firmly established. But the problems are the first, the management with VKAs is changing to their narrow therapeutic range. Second, we have unpredictable dose response. And third, others interactions, for example, with the foods. We have also direct oral anticoagulants currently approved for clinical use in atrial fibrillation with chronic kidney disease have demonstrated a benefit of those compared with warfarin, including with patients with mild to moderate chronic kidney disease. But the problem is that in chronic kidney disease stage 4 and 5 is more nausea because one, ideal therapeutic range of drug concentrations are not yet clearly established. And second, metabolite accumulation in patients with severe chronic kidney disease. Also, we have an heparin treatment, unfractionated heparin that has a short half-life than allow for anticoagulant effect to wear. And also, we have antidote protamine. But the problem is that these needs are currently those adjustment based on PTT rights per se in severe chronic kidney disease. Low molecular weight heparin are preferred for for their pharmacokinetics predictability. Uh, and don't need monitoration. Enoxaparin is the most commonly used. The problem is we don't have any data for another low molecular weight heparins like dalteparin enoxaparin in severe chronic disease. Practical recommendations for optimizing the anticoagulant treatment. First, we need to make a balancing risk and benefits requires an optimal controls of thromboembolic and hemorrhagic risk factors. Second, the anticoagulation monitoring require optimal methods and adequate monitoring calendars. Third, do not overestimate renal function, particularly in evasion chronic kidney disease. Fourth, renal function need to be checked upon initiation of the treatment after 3 months and every year. And the patients with high risk require monitoring at least every 6 months. Right, and for the conclusion, chronic kidney disease is an independent risk factor for ischemic hemorrhagic stroke. The practical consequence is that although prophylactic anticoagulation is necessary, the benefits and safety may be affected in every single person. The actual decision to use or not use anticoagulation is strictly individualized. We need to be restricted in determination of the individual profile, adequate selection of the type of anticoagulants, and careful monitoring are some extremely useful indications for overcoming management challenges. This is the bibliography, and thanks for watching.